Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yeah. Good afternoon, everyone. So I would like to thanks for the special invitation for the President Abdullah Saif and our college from UA, and of course from APSC. So we come here with the current President of Indonesian Heart Associations. I am introduce myself. I'm immediate past President of Indonesian Heart Association, but now current position is the Director of National Heart Center in Harapan Kita Hospital. Is the prominent cardiac center in Harapan Kita. Just to share about in the past when there is the COVID outbreak comes to Indonesia, we all, of course, maybe the fifth most populated country with 280 million people, and we just informed that Indonesia may be the only one country in the world that all the citizens, all the people covered by government for every single patients in Indonesia. So if you are a citizen in Indonesia, so PCI, cabbage, so the government will pay and cover by government. About the limit of the payments for every single cabbage or every single PCI. So our cardiologists now 1,500 cardiologists with interventional cardiologists, almost 500 interventional cardiologists, but there is the difference, discrepancy between the island. The big island is Borneo Island and Sumatra Island, but the most populated cardiologists in Java Island. So we try to serve our patients, our people with for optimal treatment, especially for myocardial infarction. We know that primary PCI is the best option for patients with acute myocardial infarction, can increase the survival and reduce the mortality. But some challenge facing us in myocardial vascularization, especially in patient and physician awareness for ACS, where 280 million people should aware about ACS, should aware about chest pain. Where should they go to if they suffer of chest pain? With only 1,500 cardiologists. So it is the big challenge for us. And we try to establish the networking and registry since 2008 to expanding our STEMI network system. And the challenge, of course, with the island geographical challenge and traffic. Jakarta is maybe most the city with the very high in frequency with traffic and traffic jam. But now Jakarta is more okay for transportation and gradual referral system, and of course funding. So every PCI in Indonesia, if you perform primary PCI, government give only maybe 2,000 US dollar for every PCI. So you can imagine how much the cost of stent. The cost of stent maybe now in Indonesia very cheap in the world, maybe, or only 300 or 200 US dollar one stent for people, because our government buy maybe thousand with maybe a bit the shorten the kind of stent, only 3 or 4 stent by government. So it is the challenge. These are we publish about our treatment that PCI, of course, reduced mortality almost more than 50%. We had then comparing no reperfusion and comparing also with lytic treatment. We tried 2014 with West Jakarta, is the city in the West Jakarta, a little city pilot project to improve the STEMI outcome. And 2017 until 19, we tried to expand to Jakarta. And 2020 and 2025 to 24, we try to expand to across Indonesia about our STEMI network. But in 2020 and 2024, COVID pandemic outbreak comes to Indonesia. So there is the problem when come. So it is the increasing the awareness for the physician and the population with the information and networking. We make a hub and spoke STEMI network with Jakarta as a pilot program for increasing the capability for STEMI treatment in our population. So in 2008, maybe no reperfusion 60%, but now reperfusion almost 65%, no reperfusion 35% for all the treatment for STEMI patient. So now from 11 centers in 2017 until 2019, most of the hospital give reperfusion strategy for STEMI patient, almost 65%. Then no reperfusion. In 2008, no reperfusion maybe more than 60%. And how about the option strategy, PPCI, primary PCI, the most common strategy for us for primary PCI since 2017 to 2019, the analytic treatment. So it is our expanding, and it is the outcome. The STEMI in hospital mortality rate among reperfusion strategies in Indonesia. Reperfusion can reduce the mortality almost more than 50%, and then no reperfusion. And the primary PCI, of course, give the much benefit, more benefit than fibrinolytic, more than 30% than lytic treatment. So, of course, the benefit for primary PCI was very high than the fibrinolytic treatment. But 2020, that is COVID-19 pandemic. So Indonesian almost more than 2 million people infected by COVID pandemic. So it is the picture of the performance in our outpatient clinic in Harapan Kita Hospital as the National Heart Center in Indonesia. In 2020, the yellow one here, okay, so reduce the performance, reduce the outpatient clinic in our hospital, not only outpatient but also in cath lab procedures. We in a year, cath lab procedure almost 9,000 procedures in cath lab, and every month 700 until 800 procedure in cath lab. But when COVID comes, the procedure was decreased gradually. But we only 2 or 3 months we try to increase and to try to evolve and to adapt, make some adaptation to treat STEMI patient 3 months after COVID pandemic in March or April in Indonesia. So it is try how to give service, how to optimize treatment, or to improve primary PCI intervention in pandemic situation. Should we do or we perform primary PCI in STEMI patient in pandemic, in outbreak? So it is our protocol. If patient come to the hospital and COVID positive infection, we go to fibrinolytic. But if we don't know about the patient suspected or negative, we go COVID test first and directly to the cath lab, and we make some dedicated cath lab for COVID and full personal protective equipment device, personal protective equipment, PPE, full PPE and dedicated cath lab. So every patient with STEMI, we directly to the cath lab. But the COVID test, of course, we took the test first, not for exclude if COVID test positive not perform PCI, but later, after we perform the primary PCI, the COVID test positive, so we directly go to isolation after PCI. So there is the cohort room here, cohort room. So patient after PCI, after open the culprit lesion, go to cohort room. So if the result of COVID test positive, go to isolation. So all our patients with primary PCI, we give to COVID or non-COVID patients. It is the dedicated cath lab, our our physician, our interventional cardiologist, it is me, of course, with the full PPA in the for primary PCI. There is no difference between pre-pandemic and post-pandemic. Primary PCI, of course, we still perform in Indonesia. So the outcome is the same during after outbreak, and the difficulties bed cavity, overcrowding, COVID transmission among staff. This is the improving outcome. Cath lab activation center, short screening, isolation ward extension, PPE during PCI, standard PCI strategy and protocol, cohorting after PCI, and cardiologist in charge in isolation ward. I think that is for me. Thank you so much for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much.